Hi, it's Dr. Ali, a cardiologist with 3 decades of educational experience. Today's talk focuses on aortic dissection and aortic pathology. These series of lectures are intended for medical students and residents who should take care to verify the information for themselves. This is going to be a comprehensive slideshow. Historically, aortic dissection, interestingly, was first described in the 1700s in King George III's autopsy. Subsequent to this, Laennec in the 1800s described dissecting aneurysm. In the 1950s, there were large clinical pathological series. In the 60s, the surgeon DeBakey made an operative classification. In the 70s, we got the Stanford type A and B, and nowadays we have CTA, TE, MRI, EVAR, TVAR, and these modern developments. We should recognize we stand on the shoulders of giants. Aortic valve failure is dependent on both pathology and mechanics. You have intima, media, and adventitia. There's a breakdown of the extracellular matrix, smooth muscle cell loss. There's hemodynamic stress with blood pressure, dP by dt, and geometry that forms progressive aneurysm or dissections. The AAA abdominal aneurysm is dependent on inflammation, proteases, elastin, collagen loss, and smoking. The thoracic aortic aneurysm is mainly medial degeneration, bicuspid aortic valve, hereditary thoracic aortic degeneration genes, hypertension, and aortitis. Dissection is a combination of vulnerable wall plus acute wall stress. Nowadays, we focus on multidisciplinary teams that replace solitary surgical decisions with a specialized hospital team with cardiac vascular surgeons, imagers, anesthesiologists. There's a genetic cascade screening which shifts care from isolated patient to proactive familial intervention. This patient size indexing, it's not one size fits all, and its surgical thresholds are adjusted based on the local expertise available. You have a penetrating aortic ulcer, which is an atherosclerotic aortic plaque penetrating the internal elastic lamina. You have an intramural hematoma, where there's bleeding within the aortic valve, sometimes because of rupture of the vasa vasorum or a micro tear without a primary communicating intimal flap. And you have the acute aortic dissection with intimal tear, narrowing blood to enter and forcefully separate, creating a true and a false lumen. This illustration shows the various mechanics of the acute aortic syndrome. There are various presentations. Younger, middle-aged patients with severe hypertension, connective tissue disorders, bicuspid aortic valve often have a visible intimal flap, false and true lumens. Type A would be emergent surgery. Type B would be medical management unless complicated. In the older demographic, often in the 80s, they have chronic hypertension. There's crescentic thickening of the aortic valve, no intimal flap. Again, type A, urgent surgery, type B, medical management. Then you have severe widespread atherosclerotic aortic disease with a penetrating aortic ulcer and older demographic with COPD. The ulcer crater protrudes beyond the aortic lumen. Asymptomatic is medical, symptomatic or rupture, urgent endovascular or surgical repair. It all boils down to risk factors and patient history. Is there known aortic disease? What's the prior size of the aorta? When was the image taken? Is there a family history of aneurysm, dissection, sudden death? Does the patient have hypertension? Does he smoke? What's the lipid status? Chronic kidney disease, peripheral vascular disease. Are there any syndromes? Marfan, LDS, Turner syndrome. What is the pain phenotype? Are there any malperfusions? Have recent procedures been done? Is the patient pregnant or known to have aortopathy? There are certain physical exam findings that change the management of the patient. Make sure you check blood pressure in both arms. If there's asymmetry, if there's a pulse deficit, if there's a limb ischemia, this changes management. On neurological exam, if there's stroke, syncope, spinal cord symptoms, that changes the management. If there's renal or mesenteric ischemia, mottling or oliguria, it's an emergency. If there's a new diastolic murmur, heart failure or tamponade, that's an emergency. A pulsatile mass in the abdomen, tenderness, could be sign of rupture. Look for syndromic clues, Marfan's, Lloyd-Dietz syndrome, Turner, bicuspid aortic valve features. Do not be reassured by a normal exam when the pain phenotype is high risk. Now, the Stanford type A is a surgical emergency. It involves a root in the ascending aorta. Stanford type B is after the left subclavian, and it is managed medically unless there's a complication. For imaging, you have to have strict protocols. The CT or MRI should be gated to eliminate motion artifacts. Echocardiogram should measure leading edge to leading edge at diastole. An aortic root diameter of 3.4 is illustrated here. Z-score per body surface area is also illustrated in the image. Now consider this matrix. Predisposing conditions. Does the patient have Marfan syndrome, connective tissue disease, family history of aortic disease, known aortic valve disease or bicuspid valve, recent aortic manipulation, or known thoracic aortic aneurysm? Ponder on the pain characteristics. Is it abrupt in onset, severe intensity, tearing or ripping in quality? Is the pain in the chest, back, or abdomen? Then, physical exam findings. Is there a pulse deficit? Is there a systolic blood pressure difference of 20 millimeters mercury? Is there a focal neurological deficit? A new aortic regurgitation murmur? Is there hypotension or shock? If there is no criteria, the patient's low risk. 1 criteria, moderate risk. 2 to 3 criteria, high risk. This can be made into a triage algorithm. Calculate the score. If the score is greater than or equal to 2, high risk patient, immediate CT angiogram or TEE. If it is 0 or 1, do D-dimer. If less than 500, stop workup. Consider alternative diagnosis. More than 500, proceed to gated CTA. Imaging choices. A CTA is best suited for stable acute aortic syndromes and repair planning. The strength is a fast full aorta map. A limitation is contrast and radiation. TEE, best suited for unstable patients with proximal acute aortic syndromes. It's at bedside, identifies valve problems and tamponade. It has blind spots and is operator dependent. MRI is for stable surveillance, young patients, there's no radiation, it's slow and has monitoring limits. Transthoracic echo, its best role is for root, valve, effusion. It's fast, bedside screen, does not rule out acute aortic syndrome. Ultrasound of the abdomen is good for AAA screening. It's low cost, no contrast, has limited anatomy. Report for management. The important caveats are proximal extent, branch vessel involvement, ruptured tamponade, true false lumen, diameters, prior repair and comparison. The acute medical management involves hemodynamic target, systolic blood pressure less than 120, heart rate 60 to 80. Use the beta blocker first. Intravenous beta blockers must be initiated first line. Next, add a vasodilator if blood pressure remains uncontrolled after beta blockade. Finally, pain control, intravenous opioids. Here are some sporadic acute aortic aneurysm thresholds for surgery. Ascending thoracic aorta 5.5 centimeters or 5 centimeters experienced centers. Aortic arch 5.5 centimeters. Aortic root 5.5 centimeters or 5 centimeters experienced centers. Descending thoracic aorta 5.5 centimeters TIVA are preferred. Thoracoabdominal aorta 6 centimeters. Abdominal aorta 5.5 centimeters for men, 5 centimeters for women. Now consider the 5 foot 2 inch female versus 6 feet 5 inch male. In these circumstances, consider using cross-sectional area divided by patient height. If the cross-sectional area to height ratio is greater than or equal to 10 centimeter square per meter, this is a reasonable threshold for prophylactic surgery. If a sporadic aneurysm is growing at more than 0.5 centimeters in a year, it triggers intervention. If a sporadic aneurysm has a sustained growth greater than or equal to 0.3 centimeter per year over 2 consecutive years, triggers intervention. For heritable or bicuspid aortic valve, more than 0.3 centimeter in a single year, triggers intervention. Consider the genetic syndromes. Marfan's is a FBN1 genotype, the tall stature, lens dislocations, medical therapy is maximally tolerated beta blocker or ARB. Thresholds for surgery, root more than 5 or 4.5 centimeters with high risk features or experience center. The lowest Deed syndrome is a TGFBR1, 2, or 3 abnormality. They may have cleft palate, arterial tortuosity. Medical treatment was maximally tolerated beta blocker or angiotensin receptor blocker. Based on variant, the threshold for surgery can be less than 4.5 centimeters. Turner syndrome is a 45X abnormality, short stature and coarctation, aortic size index greater than 2.5 centimeter per meter square. Bicuspid aortic valve is a notch 1 abnormality, sometimes a genetic condition. It has 2 valve leaflets. The threshold for intervention is aortic root more than 5.5 centimeters or 5 centimeters risk factors and cross-sectional index of 10 centimeters square per meter. You should always consider genetic testing in patients with syndromic features, family history of onset less than 60 years. For bicuspid aortic relatives, a transthoracic echo for valve root, ascending CT MRI if incomplete, and pre-pregnancy imaging for shared decision making and postpartum surveillance. Repair options can be open, endovascular, and hybrid. Open repair is most durable. For root and ascending, it's the standard of care. Connective tissue disease often favors open repair. There is higher early physiological stress. EVAR, TVAR is less invasive. There's lower early morbidity. It is preferred for complicated type B anatomy. It needs lifelong imaging. Hybrid approach for arch and custom anatomy planning, visceral renal cerebral protection, best done at high volume center. Decision variables include anatomy, rupture risk, genetics, frailty, renal function, access vessels, life expectancy, center expertise, and patient preference. Management of a pregnant patient starts at preconception with transthoracic echo, CT, MRI. Prophylactic surgery is recommended if Marfan with more than 4.5 centimeters, bicuspid aortic valve with more than 5 centimeter, Turner with 2.5 centimeter per meter square. During pregnancy, multidisciplinary team, maternal fetal medicine, cardiology, strict blood pressure control, surveillance transthoracic echocardiogram, and use non-gadolinium MRI over CT if distal aorta imaging is required. Continue beta blockers postpartum. If the aortic size is less than 4 centimeters, vaginal delivery is recommended. C-section recommended for chronic dissection or aorta more than 4.5 centimeters. Once you have a TVAR, if you have a type 2 endoleak, this is because of collateral backfilling. Type 1 endoleak is at attachment sites, the port seal, it's high risk. Type 3 endoleak is mechanical, fabric tear, it's high risk. Type 4 is weeping through the fabric. Type 5 is transmitted pressure and expanded sac. Post-TVAR, you have to CT at 1 month and annually or every 12 months. Post-open repair CT MRI at 1 year, every 5 years thereafter. Uncomplicated medically managed dissection, CT MRI at 1 month and 6 months, then annually after. Thank you for watching. More to follow.